Greetings, aspiring orthopedic clinical specialists. We are going to review the elbow scenario here, and the way that we'll do this is I will take us through a scenario. The scenario is fairly short, but I will take it through and I will kind of give you some key points that I would be looking at as I go through this scenario. I'm a paper person, so I would highlight certain things or circle certain things. So there are things that kind of just stick out that will help me when I think about questions that I might be answering. I'm thinking about examination questions, differential diagnosis questions, and intervention questions. So I want to glean all the information from this scenario that might help me answer any questions under those umbrellas. So for this scenario, the first thing we see, a 25-year-old male. Anytime I'm given an age, I pay attention to it. Age can clue us into certain diagnoses that are a little more likely or less likely. So we start to form a hypothesis. If someone is 25, that's different than if they're 85. There's just certain conditions that are going to be more likely at certain age groups. So I certainly want to pay attention to that. And gender can also potentially play into that. On the OCS exam, if gender is not key to the question, we try to not put gender in it. So it would just say a 25-year-old patient. But if I'm given gender, I certainly pay attention to that. So this is a 25-year-old male, dislocated their elbow doing skateboarding. Oh my goodness. 14 days ago. So now we know our injury, we know a mechanism of injury, and we know how long ago it was. That's all really important information that I want to make sure I pay attention to. Now we have some subjective information. He states his elbow felt stuck. He was unable to fully straighten his arm for a few days. Right. So now we're getting information about the degree of the dislocation, how bad it was, how irritable it was. At his friend's insistence, he went to the emergency room. Thank God for his friend. And his elbow was adjusted 2 days ago. So it was relocated, as we can adjust it as in quotes. Radiographs were taken, no fracture was seen. And currently we're given subjective information that he doesn't have any numbness or tingling, and he says his elbow feels sore. So again, I see that and I'm thinking this was a traumatic injury. We have that mechanism of injury. He's denying any type of neuro complaints. His elbow is sore. It needed to be relocated. So that tells me that it was probably, it was more on the severity scale. It was closer to being more severe than less severe. And now our question is, considering the history, what would we find? What would we expect to find during the physical examination? We're given choices like upper extremity strength, 5 out of 5. I certainly wouldn't expect that. It just says upper extremity. It doesn't say specifically elbow or shoulder, because you might expect to be 5 out of 5 at the shoulder, but it just says upper extremity. Neurovascular compromise. Well, we're told that we don't have any numbness or tingling. Normal ligamentous stability through the elbow and an inadequate range of motion into elbow extension. I wouldn't expect normal ligamentous stability. This was a traumatic dislocation that had to be relocated. So I would expect some damage to those ligaments. So the best choice here is inadequate active range of motion. The patient tells you that his elbow kind of feels stiff and sore. So I wouldn't expect that he would have full range of motion. I think there'd be some swelling in there, which would limit range of motion as well. So our best choice here is going to be inadequate active range of motion. This is a good question because it illustrates you need to pay attention to every piece of information you were given in that scenario to get this right. If you miss that last sentence, you might choose, oh, I'd expect him to have some neurovascular issues, and you'd be incorrect. So we have to pay attention to every piece of information we're given for every scenario, for every question, because it all means something. We try to not have any extraneous information in any questions. Our second question. We're designing a plan of care. Now we're asked about a forearm splint. So those that don't do a lot of hand, I'm also a CHT. Those that don't do a lot of hand, you may have to brush up on different types of splints. It's not a CHT exam, so you don't have to be super specific about every type of splint that's out there, but you probably want to know the generic ones. And for example, this question gets to that. You're considering a forearm splint. Which deciding factor is best when we're deciding the use of a splint? So it's not so much about what type of splint are we going to use, but splint use. And we're just given choices about immobilization period, evidence greater than 14 days after an injury, approved stability at the joint. A splint is contraindicated in this case, or best practice would be splint the elbow at 45 degrees of flexion and internal forearm rotation. The only choice that's going to make sense here is the last choice, which the longer the immobilization period, the greater risk for stiffness, especially at the elbow. So we don't even have to know about the splint. We just have to know kind of why you would use a splint and some splint using criteria or parameters. So the longer that we splint someone, again, especially in the elbow, it's an unforgiving joint, the more likely we're going to have a lot of stiffness afterwards. So that's our correct answer here. In terms of that first choice, about 45 degrees, 45 degrees is not a position of stability of the elbow. So if we were going to put the elbow in any type of position, we wouldn't choose 45 degrees, especially after a dislocation. So that's a little piece of information we have to know why that choice would not be the best. We look at the third choice. Now we're being progressed. So now we're told that the patient has been seen over the past couple of weeks for a total of 4 sessions. So that's important, because if we miss that piece, we think it's still the initial presentation, and we probably answer this question differently. So it's really important that we know that we've treated this patient for 2 weeks over 4 sessions. We're given more information. We don't have any notable deformity, but we're concerned with the lack of improvement in range of motion. And you're going to reassess today. Considering the original diagnosis, that elbow dislocation, we're asked about a secondary diagnosis or a concomitant injury that is most likely. So again, this is knowledge of the condition and knowledge of the concomitant conditions, or the most common concomitant conditions that might be there. And the choices were given. We have a radial head fracture. We would have known that. He had x-rays taken initially and they were negative. So we can rule that out. We have median nerve impingement. He's not having any type of neurovascular complaint. So we can rule that out. Ligamentous instability of the lateral collateral ligament, potentially. That certainly could be in play here. We weren't given any information about direction or anything like that, but that's certainly one that I'm saying that's possibly in play. But then we have heterotopic ossificans. That's the one that I am really going after, because we're talked about a lack of progress. Even if someone had instability, they'd still make progress with range of motion, and pain would probably diminish a little bit. But heterotopic ossificans, that's the one that we're thinking of, especially when it's an elbow injury and especially when it's traumatic. So that's the one that is going to be the most common, the most likely. So that's the one that you should be thinking of, and that is our correct answer for this option. And the last question we have in this scenario: which of the following may result in a poor prognosis after an elbow dislocation? So you need to know, in addition to your differential diagnosis, you need to know your prognosis for certain conditions and for certain surgical techniques. What's the prognosis after this? Is this person going to get back to full functional activity? Are they not going to get back to full functional activity? Will they have full range of motion? Won't they have full range of motion? So you have to know your prognoses for these certain conditions. Obviously, some of them depend on the information that you're given, but some of them are more general questions. This is a little bit more of a general question, just asking poor prognosis for someone after an elbow dislocation. So we're told open reduction internal fixation procedures, greater than 10 days between the injury and the reduction, limited elbow extension at 2 weeks, 14 days, or a lack of neural symptoms. So a lack of neural symptoms in this case would be a good thing, because it means we don't have any other structures injured. Lack of elbow extension at 14 days or 2 weeks, that's common. After a dislocation, there might be some swelling going on still. So not having full elbow extension is not really going to alarm me. And if they had an open reduction in internal fixation, an ORIF, that's not going to alarm me. That doesn't bode for a poor prognosis here. It's greater than 10 days between the injury and the reduction. The longer that joint is not relocated, and it's dislocated, you can do damage to structures around the joint, especially the soft tissue structures. Ligaments could be stretched, and if the joint's not relocated, those structures may not heal if it's longer than 10 days. So not being relocated before 10 days really does present with a poorer prognosis. So that's why that is the best answer for this question. And that sums up our elbow scenario. I think it's a really good one, because it doesn't just give us a straightforward epicondylosis or epicondylitis. It gives us an elbow dislocation. So if that's a condition that you haven't seen, it's good to get back and think about some of those traumatic conditions and review prognosis and the diagnosis and the management of them, because they certainly are fair game for this exam. So hopefully that helped you get through the elbow a little bit.